Morning, friends. I thank Team Disha for giving us the opportunity to chair today's session. So, continuing with today's session, I welcome Dr. K. Vijay Kumar, consultant physician and diabetologist at Sakra World Hospital, Bengaluru, chairman-elect KRSSDI, Bangalore, and he is going to speak on fatty liver, MASLD, role of Saroglitazar, a dual PPAR agonist. Welcome, Dr. Vijay Kumar.
Thank you, chairpersons, for the invite. First of all, let me once again, thank you all for attending this unique concept of silent hall. I hope you people are really experiencing it. Am I audible now better? Yeah, sorry. Yes. So, I hope everyone is experiencing it and liking it. So moving on, fatty liver and beyond. Let us talk about the new I think discussions everywhere, looking at apart from diabetes. It's been diabetes everywhere. Now, fatty liver is the one concept that everyone is wondering and worried about. Need to look at more deeper how to manage. And of late, we have got a lot of advances to even treat this fatty liver and also prevent its progression. And Saroglitazar is one molecule that has got a role in and have got some promising results. So let's see the prevalence of metabolic conditions in India. So we know this ICMR Indab 2017 study says that the cross-sectional survey of more than 11 million people here, 81.2% Indian adults have dyslipidemia with low HDL and high triglycerides, and this is the pattern that is seen. So metabolic conditions is very growing significantly and more than what it was expected to be. So insulin resistance is the key factor where these higher metabolic conditions, and especially in India, look at this YY paradox. We all know about this, and this photograph has been there everywhere in all conferences. The thin fat Indian phenotype is what we have in our country, and it's a very noted statement. So that means we have a thinner mass muscle and more of the fat outside the muscle. And this phenotype is what is caused to have a higher incidence of insulin resistance in our Indian population. So the prevalence in urban Indian obese, even school children, look at there is one cross-sectional study, 28.2% of prevalence obesity in the age between 6 to 16 years. And the overall prevalence in obese children is about 21%. 32% had the HOMA-IR about more than 2.5, suggesting a significant insulin resistance at even a younger age. 5.46 HOMA-IR was seen in obese children and metabolic syndromes. So this is the analysis that is astonishing, that's showing that the future is going to be quite difficult for the Indian population if it is not addressed early. So insulin resistance is the root cause for development of diabetic dyslipidemia and then again fatty liver. So this explains it. The adipocyte dysfunction causing hyperinsulin, and the other side hyperglycemia. Finally, it is destroying the healthy liver with accumulation of fatty liver, causing the non-alcoholic steatohepatitis and then progressing towards the end-stage liver disease. And it's more so even causing diabetes, and then diabetes is causing the fatty liver worsening. So this we need to address this pathway to mitigate the fatty liver problem, and even diabetes can be controlled well by handling the fatty liver issue. So the burden of diabetic dyslipidemia and also the fatty liver, when we look at this in our country, the atherogenic diabetic dyslipidemia is what matters. 34.2% prevalence rate has been seen the prevalence. It's a triad, the diabetic dyslipidemia, high LDL, HDL cholesterol, high triglyceride, and low HDL. This triad is because this pattern causes worsening. I mean, higher prevalence in India compared to even the Western world. The relation to the HbA1c, if we see, look at the graph on the right hand side of you. So the HbA1c less than 8, there is no ADD, 35, 44%, and those who had is 11. And when the HbA1c is increased to more than 8%, similarly the people who had the ADD is increased. So ADD patients have higher level of HbA1c, more than 8%, but the 73% prevalence is safe. So fatty liver is a new diabetes. It's high time to break the ice, and for that we need to first understand the definition of MASL. So metabolic associated dysfunction associated steatotic liver disease. It's been replaced, clearly changed. MAFLD is now defined as MASLD. So what happens here? The steatotic liver disease, about more than 5% in the liver, added with one of the cardiometabolic risk factors. It can be either elevated triglycerides, low HDL, or a pre-diabetic condition, or even diabetes, or person who is having obesity and also high blood pressure. Any of these factors, along with the steatotic liver disease, we can be considered to be having the MASLD, that is metabolic dysfunction associated steatotic liver disease. So I think the prevalence is astonishing when we come into this definition. Pan-India prevalence, MASLD is 68.2%, and then out of them the fibrosis is 33%, and those who are having cirrhosis is 12%. So I think if this kind of prevalence and the graph that I showed in the young children, we can expect this MASLD to progress into fibrosis in a large number. Fibrosis prevalence can even cross 60%. That may not be surprising. So we need to look at this problem as early as possible. So the fatty liver has a higher risk of cardiovascular diseases than even cirrhosis and hepatocellular carcinoma. The risk of MACE is 84%, and the risk of PAD is 75%. And so every other risk is there. Risk of ischemic stroke, cardiac arrest incidence is more than 50%. Risk of MI is 35%, and also a lot of bradyarrhythmias. The MASLD patients are 2 times more prone to develop ESRD with worst CKD prognosis. In diabetes, when we compare the two people, the person with no diabetes and the person with diabetes, here the NAFLD progression is much higher and much faster. So the person with no diabetes, that is about 25% in the US population, NAFLD to NASH, the progression is 10 to 20%. Whereas when you look at in type diabetes patient, it is going to be 40%. That is what we should be worrying about. And look at the mortality also. It is from cirrhosis, it is 25% higher, and the person who is having liver transplant also, the mortality can have more than 42%. That is doubling from the person who's had no diabetes. So the guidelines, EASL and EASD and EASO, all the clinical practice guidelines on management of MASLD says early screening of MASLD in diabetes, obesity should be mandatory from all the HCPs, and also avoid further risk of cardiovascular related mortality. Type 2 diabetes or obesity with one risk factor or elevated liver enzyme should be the marker, should be making us to look at screening for MASLD. FIB4 index is currently the most preferable non-invasive tool for early screening and diabetes, and this score is widely largely available on the net. Anybody can use a calculator there. Yeah. So coming to the molecule, Saroglitazar. Saroglitazar is what we have now, which has shown much promising results to handle this MASLD and also reduce progression. Let us look at the incidences. The Saroglitazar works on the insulin resistance of diabetes, diabetic dyslipidemia, and also the fatty liver. So it has got an action on 3 targets and in one molecule. So it's redefined treatment. In 2013, diabetic dyslipidemia and hypertriglyceridemia, they were not controlled with statin, and then it was added with metformin to control, and in 2020 NASH came in, NAFLD with comorbidities. All these things were all looking at treating with Saroglitazar. It is basically a dual PPAR alpha and gamma agonist, and uh, through activation of these transcriptional factors, it reduces triglycerides, reduces insulin resistance, and also controls blood glucose levels. So this has got an action on all the three parameters. So role in diabetic dyslipidemia. It is an insulin sensitizer. Saroglitazar also results in HbA1c reduction and also improved lipid levels, that is triglycerides, reducing triglycerides in non-HDL and also improving LDL cholesterol. Saroglitazar has shown improvement in the glucose metabolism and insulin sensitivity. So this is a single center randomized double-blinded placebo-controlled trial where both treatment naive diabetes patients, which is HbA1c 7 to 9%, with the serum fasting triglycerides more than 150 were included, and the subjects were randomized to receive Saroglitazar 4 mg placebo with a distribution of 4 months. Study duration was about 4 months. Look at the insulin sensitivity results. From baseline, the sensitivity insulin sensitivity is shown to be increasing from 2.9 to 6.1, whereas the glucose metabolism from baseline to 4 months, it has quite doubled. So the glucose sensitivity has doubled in 4 months. So Saroglitazar has shown to improve both glucose metabolism and also insulin sensitivity. So Saroglitazar reduces elevated triglycerides, non-HDL, HbA1c, and also ALT in diabetic dyslipidemia patients. This is an integrated review analysis with 18 clinical studies and more than 5,000 patients included in all these studies. The data published in the cardiovascular dietology in 2019 says that triglycerides were about 45 to 62%, non-HDL 21 to 36, and the HDL 20%, and HbA1c 0.16%, and the ALT reduction is 28 to 67%. This much of reduction is seen with the usage of Saroglitazar, and that's where it has got a very good point where we can address the fatty liver problem. So RSSDI 2022 also consists decision pathway and triglyceride reduction also says that first stratify the risk for ASCVD, and if there is higher risk, we have, and if the person is having higher triglyceride risk, statins, fibrates, Saroglitazar, and then omega-3 fatty acid. These are the molecules that are straightforward recommended for the treatment even in the RSSDI guidelines. So role in fatty liver, looking at the liver, ALT and AST enzyme reduction, and it also reduces liver fat, and significant fibrosis reduction is the three major results we have seen using Saroglitazar. So it reduces ALT and AST. What is the difference? Earlier we used to have this UDCA. Looking at UDCA, the effect on ALT AST was 40% of reduction in ALT and 33% in AST reduction. But look at the other parameters. Effect on insulin sensitivity and MASLD, was it approved for MASLD treatment? No. So the impact on metabolic profile was not seen with UDCA. All these things are seen with Saroglitazar. There is 30% reduction of liver fat content with usage of Saroglitazar, and the effect of liver fibrosis, that is 25% improvement in the fibrosis grading. And the guidelines now, many guidelines have started recommending Saroglitazar for MASLD treatment. So this is the one and first molecule that has shown to have variable and very promising results with the usage in the MASLD. The evidence tool study shows that there was not only fat reduction, there is also liver fibrosis score reduction that is improved in the first ever liver biopsy driven study of Saroglitazar. The graph says it all. The decreasing NAFLD activity score more than 2 was observed in about more than 52%, that is more than half of the patients without worsening of fibrosis at 52 weeks. That is the result with usage of Saroglitazar. And liver fibrosis, early liver cirrhosis and advanced stage, if you look at 52 weeks, this observational study having 112 MASLD patients, those with or without diabetes, were included in the study and given for 52 weeks. So the CAP score and the LSM scores were evaluated through the fibroscan, and the grades were, and so each grade, if you see, from F0 to F1, there is 10% reduction, and F2 reduction about 24. So if the person is having F3 fat score, that is fibrosis growth, there is a reduction of 24%. So at 52 weeks, at all stages of fibrosis, you have a good reduction, promising reduction that I see in DTC using Saroglitazar at 52 weeks. So the role of Saroglitazar in MASLD as a follow-up up to 144 weeks. So the KPA study, there is a reduction from 22.8 kPa to 10.9 kPa. So that is, there is a significant change in liver fibrosis over time. So when we use it for longer duration also, there has been a good reduction in the kPa and fibrosis score. And the endocrinology, diabetes and metabolism, the effectiveness of Saroglitazar in MASLD patients, a prospective real-world assessment. Here, there was a single-arm multi-center study in North India, 50 patients with MASLD diagnosed by a fibroscan. Saroglitazar 4 mg used for 6 months as a treatment along with the standard of protocol. Primary objective was to evaluate the changes in the LSM and CAP score at 6 months. The results showed the reversal of fibrosis in 63.6% of the study population had liver fibrosis regression from F2 and to F0 or even F1. So there is a reversal of steatosis. Steatosis also, more than 50% of the study population showing regression in 6-month therapy. S3 score to even leading to S0 or at least S2. Triglyceride reduction was seen in about more than 60% of the patients from 200. Those were triglycerides were patients who are having more than 200 milligrams per deciliter. Also, there is another study called the evidence 11. Here, the effectiveness of Saroglitazar and safety was studied. More than 1,500 patients were recruited and 19 centers across India and treated with Saroglitazar, and the intervention was studied through fibroscan. Duration of study 24 and followed up to 52 weeks. Changes looked at change in LSM, the lipids, sugars, liver enzyme profile, change in weight and BMI, safety parameters and side effects. The AASLE 2025 interim analysis of 1,000 patients were presented. That is, there was from baseline, the reduction in LSM was at 24 weeks was up to 8, and then at 52 weeks was 7. So there is a good reduction in kPAs that was noted even in the interim study of 1,000 patients. So finally, this real-world study has with more than 355 MASLD patients at 24 weeks, looking at the cardiovascular risk reduction. 10-year CVD risk reduction by 9.27 relative risk reduction in Saroglitazar, that is dealing with the fatty liver, and also there is a 11.8 risk reduction at 24 weeks with CVD risk. So 9.2 10-year CVD risk, 10-year ASCVD risk at 11.8% reduction. So that was the relation that we could see using Saroglitazar even with the cardiovascular disease. So in summary, Indians are more prone to develop metabolic disease due to higher risk of insulin resistance and higher consumption of carbohydrates. Diabetic dyslipidemia with triglycerides with 34% prevalence in India and increasing the MACE levels. And fatty liver is now considered as the new diabetes that should be treated in early stage of diabetes. Saroglitazar, being insulin sensitizer, can be the one-stop solution for diabetic dyslipidemia and fatty liver proven efficacy and safety. This was pretty much. So these are the 3 points.
Thank you very much, Doctor. It was a very nice lecture. Saroglitazar was the first drug which was introduced in India for diabetic dyslipidemia. Important thing is it addresses 3 core issues in MASLD. It reduces insulin resistance, it improves the insulin sensitivity, and that is the main cause of fatty liver. it improves the fat dysmetabolism, and that way it improves the hepatic steatosis. The third thing is it reduces inflammation and attenuates the progression of fibrosis in MASLD. If there are any questions to doctor, please.
There, yes.
So since it is a dual agonist, can it help in reducing the blood sugar also? Can it be given for pre-diabetics in prevention of diabetes?
Yes, it's like the slide showed, it also improves insulin sensitivity and glucose metabolism. If even if pre-diabetic, if they are having a good, like early MASLD, definitely works good, and even, maybe it can help in preventing progression to diabetes.
Yeah.
Also.
Again, in diabetic dyslipidemia, as it reduce the blood sugar level also, along with
It
reducing.
does help. It does help.
The alpha agonism with the Saroglitazar, it helps in reducing insulin sensitivity, but it has not been approved for use in diabetes.
Use of these drugs, use of Saroglitazar in patients who are on GLP-1 receptor analogs, because they can also be helpful for MASLD as well as MASH. So, are there any data available with combination of these two, and what is the effect? Will they move faster? Is the improvement faster if used in combination?
Data, I'm not sure about that, but I have seen quite a lot of people doing it, even the gastroenterologists, who are treating the fatty liver or worsened cirrhosis people also. They have been using Saroglitazar along with the GLP-2. I've seen that, but personally I've seen some good improvement in the parameters.
SGLT2 inhibitors, GLP receptor analogs, and Saroglitazar. Three combined we're talking about?
No, GLP and the Saroglitazar.
GLP and Saroglitazar. Okay.
Yeah, Vijay sir, follow up to this, I have seen a lot of prescriptions, and I have personally been using SGLT2 inhibitors along with Saroglitazar and vitamin E UDCA in people who are progressing towards fibrosis. Means they have not gone into fibrosis, but maybe they are alcoholics or they are smokers, and I have seen beautiful results. And along with that, addition of vitamin E as well. So, means these are the real patients which I am talking about. What is your take on that?
Yes, earlier we used to use UDCA, vitamin E and omega fatty acids for the treatment, but now the GLP-1 has come. That is the first go-to treatment for the MASLD fibrosis also. But along with Saroglitazar, there has been some promising improvement. But vitamin E, these things, it doesn't, they lack any evidence actually. They don't show much of evidence.
The only drug which has been approved now for fibrosis is resmetirom. That is the only drug which has been approved. Steatosis, all these help. Because it reduces inflammation, there are fair chances that it will reduce fibrosis also, but it is still not approved for fibrosis.
Yeah.
There are no DCGI approved drugs for this till date, because Monjaro is there, but it is not approved by DCGI. We don't have it, means not for this purpose.
Not available in India.
Yeah, but it is not approved by DCGI. It is coming in March next year.
Dr. Yeah. Can I have a question? With the Saroglitazar and also metformin combination, weight loss is one of the common condition we are seeing, especially in lean diabetics. They lose a lot of weight. What is your experience?
Metformin and Saroglitazar. Both are weight neutral. They don't have any direct effect on weight. But maybe as we have observed, I'm not sure. It could be because of the metformin and the diet and those things that could have been helping. Directly, how much weight reduction is anybody else has got any experience with metformin and Saroglitazar weight reduction? I have not come across with that.
Okay. That's right. Thank you. The audience can also use the mic which is there in the center of the hall. If there is any difficulty to pass on the mics.
Yeah. I think probably the last question. Your time running out, I think. Well, you told about the experience with weight gain in weight loss. You was talking about the weight loss actually. But I found that quite a few of my patients, there is a mild weight gain rather, not as a combo, as a pure Saroglitazar. This one I wanted to add this point. What about your experience? People only on Saroglitazar, there is a mild weight gain as a side effect.
So but there is no proven study that it can increase the weight.
Thank you, sir.
Just a small announcement, we are trying this silent hall for the first time. You can see the hall A here, and if you can press the button, mine is in green. Your people who are listening to this hall is having red. If you can change it to the green hall, you can see the slides here, and you can, without running there, you can also listen to this thing. There's a button there. So we can enjoy without running up and down. Thank you so much.
Physically here and mentally there. So everywhere. That's the use of technology. And kudos to the team, Disha, for introducing this innovative idea and making use of technology, the smartness what technology has to offer to us. And with this, I request the chairpersons and the speaker to gather for a memento and the capture of this moment in the space which is next to the hall, sir, in between both the halls. We can take a photograph together.